going back to veneers, let's talk a little bit about, let's say, ceramic veneers. There's always some complications that could happen, right? Whether it's from the doctor or from the patient. But what is this expectation of warranty?
Oh,
Do you actually give patients warranty? And why is it an expectation when it comes to dentistry that we fix something and it will survive forever? Because that's the first question they ask you, right? When you're talking about a treatment plan, be like, how long does this last? How long does this treatment last? And is it, especially for implants, like, is it forever? I'm like, well, no. But what's your thoughts on this dental warranty thing?
I think it's very common in this part of the world as well that, you know, you see these advertisements for people saying, you know, we include any repairs and chips and warranty for like 2 years or 3 years. And it's part of a marketing gimmick, I feel like. Personally,
So it's a scam.
I think so. I think
agree.
so.
Well,
I
we saw a lifetime warranty, which was something ridiculous.
All the time.
lifetime warranty.
Oh yeah.
Lifetime warranty.
Lifetime warranty.
Sign me up. I'd love to see that. But, you know, I think the discussion usually comes down for the patient, which is always misinformation and education. I always reply back by saying, you buy a car, does it last forever? Does it not require warranty and maintenance and things like that? But they always say, yeah, okay, they give you 3 years. But I'm like, but things do go wrong.
No, but the tires. I use the same example, but I say the tires.
That's a good one.
I say the tires, you're using the car just to go to work.
Yeah.
You're using your teeth 3 times a day minimum when you're eating.
True.
So, and if you buy a brand new car, you drive it out of the lot and you go on a nail and you puncture the tire, they're gonna charge you for that new tire. It's not gonna be free, even though you just walked it out of the lot. So that's the example I usually give is the tires. Be like, how often do you change your tires? They tell me every 6 months. I'd be like, okay, well, teeth are a little bit better than that.
Exactly. No, I think that's a perfect example, and I really like that. I think you could add on to that. I always say that as dentists, we destroy teeth. What we're doing essentially when we pick up the handpiece, we're just delaying the inevitable. The tooth will eventually be lost at some point. The more you restore, the larger the filling may become. You know, you see amalgams now that are failing, the cusp breaks off. MODs from premolars have been root treated, and you're just then trying to provide cuspal coverage, and at some point eventually break off. So what we're trying to do is delay the ultimate or the final result, which obviously be extraction for a tooth. So I think, you know, with that mindset, you tell them that we're trying to delay that process. We can never give you something that's going to last forever. I can never look at you in the eye and say this is going to be in your mouth for X, Y, and Z. Because again, patients also have habits. You know, they might be okay for now. The next time they come in, they've started, I don't know, drinking.
Yeah, but they have a cavity, and it's like, how's that my fault?
Yes, absolutely. You know what I mean?
Exactly.
Yeah, but let me play devil's advocate. So you just say that, okay, we're just, you know, things could happen, and then what the patient will say is, okay, then why are you charging me this much? I'm just gonna go elsewhere and get it for literally 10 times cheaper, and then just replace it every year and get a brand new veneer every year. You know, but I think this is also where the issue is. Like you said, every time you're replacing it, you're breaking it down. So you might not be able to replace the veneer more than a couple of times, because then you just every time you're replacing it, things are going wrong.
That's the thing. I think the process of replacing anything that we do invariably will always remove more.
Right.
You know what I mean? That there's always going to be more destruction, and ultimately things might not work as what it was the first time. It's not like a clean fit where you just remove a tire and put it back in again.
And I think this is one of the big issues with veneers in particular in the UAE, is they're seeing it as a product. It's something that you purchase, and it's not a product. It's health. You know, having a healthy smile is more important than having a bright smile.
That's true.
And I think that mentality of, hey, I'm just going to replace it every couple of years is extremely wrong, because that's the health of your teeth. And I had a podcast with Haitham Agha, and he was like telling me that there's P. gingivalis for periodontal disease.
Yes.
And obviously we know poorly done veneers cause periodontal disease. And they found a link of the protein that P. gingivalis secretes, which is gingipane. They found in Alzheimer patients in their brain.
Oh.
So now there's a kind of link. I don't know if it's an actual association, but there's a correlation between gingival disease, which is periodontal disease, and Alzheimer's. which is and we already know that there was that same protein in plaque in atherosclerosis. So I think this is very important, at least for the public, to understand that the teeth and veneers and all that is your health, rather than just a product that I can just replace whenever I want, like tires.
Yeah, absolutely.
Yeah, actually, the way we used to do it in the US, going back to the warranty thing, we used to, if something fails the first year, we used to charge 25% of the fee, of the price of that veneer. And the second year, we used to charge 50%. The third year, 75%, and then the fourth year, we used to charge full.
I like that a lot. I like that a lot.
Yeah, because after four years, I mean, the patient has used it enough to be replaced at least. I always tell the patient, because they come to me, and just like I said before the podcast, the lifetime warranty, and I told that example to one of my patients. If a cardiologist do heart surgery for you and tells you that, look, you're gonna live forever, would you accept that? And then look, everything has a lifetime.
Right.
And by book, porcelain lasts for like 7 years. It fails at some point, whether
it's aesthetic reasons.
Static reason could fail, could crack, anything could happen. Even aesthetic, even if change color, that's a failure.
Yeah.
Okay. But nothing lasts forever.
Right.
That's what the patient should understand.
And one thing that baffles me is that you look at a cardiac surgeon, and he tells you this procedure is 60%, or hip replacement. You know what I mean? That's another example. Nothing with respect to our medical colleagues that they do usually hovers between 60 and 70%, even for hip replacements. And you end up leaving the hospital with an infection and so on and so forth. But patients seem to be acceptable. Like they're okay with that. They accept that. But when we come and we say, okay, implants do have a very high survival rates in comparison to medical prosthesis, but yet they become very agitated and angry when things don't go their way.
Yeah.
Which is why I never really managed to grasp as to why this seems to be happening in our profession.
Yeah.
But when medicine, okay, 60% seems to be in relation to dentistry, quite low.
Very low.
Very low, isn't it? So you look at everything that we do, whether it's just simple class 2 composites or composites. I'm start with 2 Americans. Or with implant survival rate, it's in the high 90s.
High 90s.
And 20-year survival now being released is still phenomenal. This is survival, obviously, is an amazing number to see, but yet we don't it's not appreciated by the public, and I think that's a sad fact. So you tell somebody, like my dad went through, cardiac procedure, but the numbers are not 100%. But yet it's fine. We'll go ahead with it, and if it fails, then we'll address it. We'll go with Plan B. Accepting, and obviously we completely understandable. When it comes to us, there's always this notion that it needs to be lifetime or it needs to be for a very long time. But what is a long time? As you said, you use your mouth 3 times a day to eat. That's excluding snacks, obviously, and what you do, and any parafunctional habits that will obviously
or
increase.
Chewing gum all day.
There we go.
Yeah.
Absolutely.
Yeah. But I still, it's funny. Like when I first moved here, I was like trying to get advice from other clinicians about how do I approach, because I had a very big difficulty talking to patients.
Yep.
And remember, I was moving from New York City to Al Ain. So the dental IQ was much lower. And I had difficulty explaining to patients. And I had multiple clinicians come to me and tell me, you are explaining too much. You need to tell them that everything will be fine. And I found that really like baffling, especially coming straight from the US. And I'm like, they need to understand the pros and cons of these treatments. And then they're just like, hey, they just want to know that it's gonna be okay. Just tell them it's gonna be okay and move on. What do you think about this approach?
Well, I mean, I got this exactly the same. Just like when I moved there, I used to explain a lot to the patient. Try to push the patient to read the consent form, which they don't read it.
They don't read
just
it.
Go straight to sign it. I mean, I'm like I would go to kind of make things simple, or like explain it in a simple way to the patient, rather than hiding the
Yeah.
pros and cons. Okay, so I would always explain it like, okay, even with implants, like survival rate is pretty high, but there's always a chance that this would fail. I mean,
Yeah.
it's your body; it could reject it, could accept it. It's your body, so patients should understand this. And I guess this would be if something go west or south, patient at least know that, okay, this implant failed because doctor explained it. And I still explain things to patients,
Yeah.
honestly.
Yeah, I still do too.
Despite all the,
Yeah. Yeah.
the recommendation that
Yeah.
don't mention this, you don't have to tell the patient that this could fail. Just like, for example, smoking, that's gonna affect. Yeah, it's gonna affect. I have to tell the patient. I ask the patient if they
Yeah.
smoke or not.
And I tell them 11%. Studies have shown that it decreases
Exactly.
the success rate by 11%.
Yeah,
And you have
the
to be
chance
aware of that.
failure goes higher with the smoking. Even not on, sometimes the implant is successful, but I would say the post-op, I would say pain or delay in healing. This all with the smoking that would,
Yeah.
patients should understand this. I mean, we're a clinician at the end. We interact, directly with the patients. It's just like not like a robot that just go do and ask the patient to leave. So yeah.
Yeah, yeah. Speaking of smoking, I had this one incident. I remember my first year in the UAE. I was doing a full arch implant placement, and the patient, because it's a long procedure. I usually book the patient for like 4 hours, especially when I first got started. And I opened up the flap, placed a couple of implants, and I still needed a couple more implants. He's like, I really need to go to the restroom. I was like, okay. I put some gauze and everything. He comes back smelling like smoke. He just went to the restroom and smoked his midwah, and then comes back, and I was like, did you smoke? Your bone is exposed. He's like, yeah, it's fine. I'm like, dude, no,
Can you
you
imagine?
cannot.
Can
You
you
cannot
imagine
do
that?
that. Like how? Like I was just like in shock. But so it brings me to another question. So when, in our education, they always say patient selection is so important. Everybody smokes, especially in this country, and people who don't smoke cigarettes probably smoke like hookah or something like that. Is that a contraindication for you?
It's not anymore, honestly. I just because we've seen, I would say like more than 60 or 70% of my patients, they do smoke,
Yeah.
and the success rate is pretty high. So I can't tell them like, okay, I can't give you implants because you smoke, because everyone smokes.
Right. Exactly.
So it doesn't make sense anymore.
Exactly. So we can't do that patient selection thing.
Yeah, and but I always recommend them to cut smoking at least the first few days, just to have better healing, less complication. But excluding them from implant doesn't make any sense.
Like
to
the
me.
actual recommendation, I looked this up, like scientifically speaking, 1 week before they need to stop, and 3 weeks after, which is an entire month of them stopping, which is
Which they will
impossible
not-
for those.
they will never do
They
it.
will never do it.
Yeah.
But so when it comes to it, I always get this question, Doc, I'm gonna smoke, regardless of what you tell me. I'm going to smoke. But do you prefer me smoking vape or tobacco? What do you say?
I don't know if
It's a good
you've
question, right?
I don't know if
It
you've seen
stumped me.
any research about this, like the difference or the impact of each one on implants.
Mm-hmm.
And if I don't know if we were together maybe in one of the meetings, the presenter was saying that it's not the cigarette per se that's causing the failure. It's the tartar or the plaque that could,
And also the heat.
yeah, the heat that is coming from the cigarette itself. So the different whether like give them option, okay, you can go for vaping or tobacco, or go for some hookah maybe just to to compensate the tobacco in your body. I'm not sure. I haven't seen any research.
Yeah, there isn't any research. So that's why, like, because it's unethical, right? You can't just tell somebody, make a research, be like, hey, I need you to smoke and I need you to use a vape.
I think
that's the recommendation.
like you'll go to
You can
jail.
go for tobacco, two pills of ibuprofen.
I think it's a very difficult concept to kind of research to carry out. But there has been just some position papers regarding just some information about, e-cigarettes versus tobacco smoke. Not with relation to
Okay.
implants, but in relation to just teeth.
Okay.
And that came from the British Society of Periodontology. And they did say that looking at the indices, the periodontal indices of non-smokers, versus smokers versus people who smoke cigarettes, because there've been some publications coming out in the early days, and there's clearly a significant difference between smokers and tobacco smokers, cigarette smokers, and
Vaping.
and vaping. So obviously, vaping has a lesser effect when it comes to the biofilm, and naturally speaking, in terms of periodontal parameters, bleeding on probing, and so on and so forth. So that, when you look at which is worse, yes, I think we could all agree that cigarette smoking is probably the worst when it comes. And there's evidence for that for the last 70 years now. But when it comes to e-cigs or vaping, the jury's still out, because they always end research papers by saying long-term studies are still required. I mean, that's always the ending of every research paper that you read.
Limitation.
Yes, it's a limitation. But you're looking at the parameters itself. I personally would feel safer to provide an implant to a patient that is on vapes than that smokes.
Right. Same.
Does that make sense? I would feel comfortable sleeping at night thinking, okay, he's not at a high risk. The risk is there, but the risk is lower.
Yeah. I always actually, first thing I tell them, try a patch or a gum.
Yes.
And if that doesn't work, then you got to do what you got to do.
True,
You got to get your hit.
And I feel like when you
Tell me how you did that.
I feel like whatever you tell them, they're gonna do what
they want.
Exactly.
Yeah.
And,
So if he is a smoker or he or she is a smoker, do you give antibiotics just to be safe? I know it's a very touchy subject.
Well, I wouldn't, honestly.
Okay.
I don't see a correlation between smoking and antibiotics. I don't know what the antibiotics gonna do for a smoker, honestly.
Yeah.
The only instance that I would prescribe antibiotics is when I do extraction of a tooth with infection, and when I use bone graft mainly.
And sinuses.
Yeah, and sinuses. Yeah, which it involves bone graft. Other than that, I don't. Like, for the reason that patient smokes, I don't. No, that's,
Okay.
Yeah.
Now, question. I'm sure you've had this before because it happens to me all the time. Patients think they get a better outcome with antibiotics, meaning that a lot of times we do procedures, whether it's an implant or even an extraction, that does not require antibiotics. But the patient requests antibiotics. What's your thoughts on that?
I think I'm
Stumping you guys again.
we get this. I'm sure you get this.
I get this all the time.
Yeah.
I get this all the time.
I mean, my response is always, if you're taking a tooth out, and I always say to them that you haven't got any systemic effects. Systemic features, and then raised temperature.
The source of infection is gone.
Exactly, and it's a bit like I always give them examples. Having a splinter underneath your skin, I just removed the source of it, so therefore just give it some time for it to heal.
Oh, I like that.
Yeah, so there's no need for you to have any more antibiotics. Does that make sense? So I mean, they understand that. Like, okay, and I always give them.
What if you were like, okay, but then they come back with dry socket because they didn't follow the post-op instruction and said, I told you should have given me antibiotics.
Well,
'Cause that does happen.
So yeah, I was gonna just finish it off by saying that this is my details. If things don't heal in the next 5 to 7 days and things are going south, come back. But there's a risk of dry socket, again, as you know, smokers and people who just, obviously there's absence of a blood clot that's there. And in a rare case, that's an explanation that needs to be done. But the prevalence of that happening is low. And I feel like it doesn't justify us giving antibiotics prophylactically to every extraction site, for instance, or an implant placement that is with minimal mucosal manipulation or grafting. So there's no grafting, then it makes no sense. Because the bigger picture here, which is a worldwide problem, is the antibiotic resistance that we have.
Right. Oh, yeah.
And I think as dentists, maybe perhaps we're not as bad as our medical counterparts, but it is an ongoing problem. And I think we need to bear that in mind.
Yeah.
The dosage and the duration.
Yeah.
Therefore, as you said,
Yeah.
I agree with the implant protocols. It's been, and that's similar between the UK and the US. Prophylactically, and when you do that, and there's some evidence to suggest that affects survival. But to give it based on patient's request or based on smoking status is a no for me.
Yeah. There has been studies that showed better outcomes of survival of implants prophylactically giving antibiotics.
Correct. Yeah. Yeah, I think there's been long-term systematic reviews, and they all mention that, and I think that's why the push is.
Okay.
Yeah, but that's the issue that we have in clinic when the patient comes back, just like what he said. You don't give the antibiotics to the patient, and patient gets some complication, and he would blame it on the doctor for not giving him antibiotics. That's a
Yeah,
problem.
yeah,
Like,
that's a
patient don't
big
understand
problem.
that that's not the reason. It could have happened anyway. Like,
Exactly.
I mean, I can't prescribe antibiotics for every single
Right,
patient
right.
just to avoid a complication that could happen and could
Right.
not.
Right.
So yeah.
And I think indirectly we can make it worse by the global problem of having antimicrobial resistance, because they end up not having any issues, no dry socket, everything heals. They stop taking the antibiotics. They have a few spare pills. They get a common cold,
Yeah. Yeah.
a viral infection, and they start taking those pills.
Yeah,
Oh, the dentist
yeah.
gave them to me, and I have 3 pills left.
Yeah,
So I start taking
yeah.
them, and then the whole thing just becomes a
Right.
mess.
Yeah.
Does that
Yeah.
make sense?
Exactly.
And I hate it when they talk about the other doctor. We're like, oh, last time I had the tooth extracted, they gave me antibiotics. Last time I had an implant, they gave me antibiotics. Why aren't you giving me antibiotics? Always get that. And speaking of that, comparing you to other doctors, the other day I had this interaction which really surprised me. So I was doing these crowns, and I was replacing crowns.
Yeah.
And I was putting cord in, and then the patient was like, "What is that?" And I was like, "Oh, that's cord to separate the gums from the tooth, so we can get a very good scan." And he's like, "Why do you need that? My other doctor did a great job and didn't need to use that. Is it because you're not good enough?" She literally told me that. She literally told me, and I just looked at her and I was like, "Yeah, I'm not good enough."
I just pulled the retraction cord out.
I literally told her that. I was like, well, this dentist must have been phenomenal to take a scan with
Yeah.
with perfect margins without a cord, but I'm not good enough to do it without the cord. And she started laughing. I'm glad that she took it as a joke. But I just found it like really surprising, like let's call it the dental IQ, like when most dentists are not doing the normal thing. So then when you're doing the normal thing or the standard of care, patients see that as you not being good enough because you have to do an extra procedure or an extra thing to do a good job.
Yeah.
And that drives me crazy. That really grinds my gears. Okay. Zirconia implants. Yesterday, I actually had a discussion with my Neodent rep about zirconia implants because they just started them in the UAE. What are your thoughts about those?
Well, I still don't think that that would perfectly work as titanium implants. I mean, titanium implants have been the standard of care for dental implant, and for any part of your body where they need to fix something and put plates and screws. Titanium is the material that's biocompatible with the bone or our body. Zirconia, I mean, it's a tough material that's like Straumann, they have it like in rock solid, like 50% zirconia, 85% titanium, just to make the zirconia or the implant stronger. So the zirconia is giving strength to the implants, but the biocompatibility with the bone is coming from the titanium. So I wouldn't do it at this time. Probably in the future, and I don't think in the near future and like the zirconia, they have improved it, a lot since like they started using it for dental. That was like almost like 20 years working on it, and this zirconia implant has been out for like almost 10 years now. Yeah, but it wasn't like really implemented in as a standard of care.
Right.
It has, when you think about it, it has some advantages, which is mainly the strength, and having something tooth colored, not having the titanium reflecting the shadow through the bone and tissue. But depending on zirconia implant, I don't think we're there.
So you think it's more of like a trend?
Yeah.
Out of interest, was the discussion with Neodent one-piece implants or were they
Two piece. two-piece, but it was interesting because he was explaining to me that the implant itself is zirconia and the abutment is zirconia, but the screw is titanium. That's for neodent. For Straumann, the abutment is still titanium. So I found that very, very interesting that the screw is still titanium.
Well, I mean,
But it makes sense. Makes sense. It's gonna
they
be
have
very
to-
thin. You torque it a little bit, it's gonna crack.
yeah, I mean, zirconia, when you have a thin,
Yeah.
margin of crown, zirconia crown, it could crack
crack,
easily.
yeah.
I mean,
It's a brittle material.
I think it's an interesting thing. It's the kind of, from my experience, the people who come in requesting zirconia implants are the ones that always claim that it's metal. They want metal-free implants, which they clearly are misinformed because zirconia is a metal.
Yeah.
If you see what I
Right.
mean, zirconium oxide.
Yeah, people don't understand.
Is
this-
they don't understand
this
that
point,
concept.
yeah.
You know, they walk in, as soon as they walk in, it's like metal-free flag. This is what I have. You're not going to touch me with anything that's metallic. But that case selection was very low.
Yeah.
I've had a very. So we had I remember back in Florida, they had a cupboard that was just for zirconia implants, but they weren't used that often.
Yeah.
So I would say, it was less than 10%.
They're not
That's
as
just the figure.
versatile,
No,
Like
not
for
at all.
us as prosthodontists, whenever I'm placing an implant, I'm always also looking for the future, right?
Correct.
So we're planning for the failure. So for example, let's say placing 2 implants here, 2 implants here. I'm gonna try to put them in the same depth, right and left, just in case in the future we need to get rid of these. Just place 2 more implants here, and then we've got a full arch. When it comes to zirconia, if we want to convert a prosthesis or make it more versatile, you can't do that with zirconia. It's just that. It is what it is, and then if you're gonna change the treatment plan, you're gonna have to remove it, and then that's even more destructive.
It's restrictive.
In my
And
opinion.
I've used zirconia abutments a few times only.
Okay.
And if you ask people who use zirconia abutment, the only or the most common complication is fracture.
Yeah.
The zirconia, I mean, now you're telling me to use zirconia abutment on zirconia implant, and that could go really wrong
Right,
at some
right.
point. And if it goes wrong, it could go beyond repair. You're talking about possibly like either implant breaking or the abutment breaking
Breaking,
inside the implant.
The
And
drills
it's-
breaking because the drills are also zirconia.
Yeah, I mean, it doesn't make any sense to me.
Yeah.
I don't know.
I think it's not there yet. But I am interested in finding the right patient to do it on, just so I can have some experience in it, so I can have a more informed thought about that. But when you did use a zirconia abutment, what was the width of the implant?
It was 4.5.
Okay.
Yeah.
Okay. Yeah, because I think the latest study for zirconia abutment said that it's contraindicated in anything less than 4. And anything in the posterior. So that anything in the anterior diameter more than 4, they're like, you can use it, but with caution. You know how they write in the articles, with
Yeah,
caution.
with caution, yeah.
Meaning
It might
no
break.
bite on it, no nothing on
Yeah,
it. The
don't
patient
use
is
it.
not
Just
a
don't use it.
boxer.
It's just for smile. For aesthetic
Just look at
reason.
it. Yeah, that's it.
For taking pictures.
Yeah, I don't know. I think hybrid abutments, like having a tie base with a milled custom abutment, I think it's very good. And I think the issue with the gray showing, like a small soft tissue graft, a connective tissue graft,
Yeah, I
it's
was
gonna
gonna
solve
say,
that.
that was
you know,
the problem,
like,
yeah.
Then to like remove an implant because of unless it was placed incorrect, because most of the time that shows is when you're placing a two buckle. That's a whole different story.
I honestly can't think of an indication.
Yeah.
Why would you use
Yeah,
zirconia?
unless the patient requested it.
Yeah, that's it. Because it's
I haven't seen anyone that like any patient that's like they have allergy of
Yes.
titanium.
Yes,
That's the
yeah.
thing.
Yes.
I
No,
mean,
but the zirconia implant still has some titanium in it,
yeah, that's the thing. That's the thing.
right? So.
Yeah. But
I don't know.
to
I don't know.
them, to that person who's
Yeah.
asking for zirconia,
Yeah.
to him, he's getting a full zirconia implant. Which,
Yeah, and I think also some of the doctors are not informed. They think it's a zirconia, it's a pure zirconia, but no,
It's
there is
not.
still some a little bit in there. Now going to the actual surgery, insertion torque. I think we had this talk before. I thought it was a very interesting debate. What's your thoughts on high insertion torque? Meaning more than 60. I think we see sometimes 100. Do you think that is actually very bad for the crestal bone, or do you think we can get away with it?
Personally, I think you can get away with it. I think in this
Okay.
day of age, I think the classic teaching has always been, 35 to 45 is what the incision torque is. And you look at how, I think going from literature, just looking recently from what the systematic reviews have seen and the split reviews, they've said that they compared the incision torques between that were high, at 60 and above, and they found that the crestal bone loss was not statistically significant. So it's not really like a red flag, as they would say anymore. To add to this, I feel like the new implant designs now that are coming up from like Straumann, like the BLX and the TLX, with a really aggressive thread and pitch, those automatically, they're kind of
high insertion torques.
they get high insertion torques from just the experience that I've had. So I feel like the shying away. I mean, I've never had 100, but shying away from that because that will cause necrosis of the bone and eventually will cause, some bone changes. I feel like that is multifactorial.
Yeah.
It comes from
And
irrigation.
relatively reversible, maybe.
Correct.
I don't know. Oh, we had this discussion.
What do you
on
think?
debate.
I never
before.
heard your opinion.
Honestly, I don't feel comfortable over torquing an implant
What is over torquing for you?
above 50.
Above 50.
Yeah,
Okay.
once I reach to 50 and the implant is not down to the the position that I'm planning to.
What do you do?
I would
Remove it?
over drill and then put it back. The thing is, in this situation, first thing, I'm losing the tactile. I don't know if I'm at 100 or I'm at 200 or
Right,
at 300.
right.
I'm losing the tactile because like most of the wrenches that we have
Or up to like 60.
up to 60, sometimes 75, like tops. But when you say that, okay, I'm torquing at 80, do you really know that you're torquing at 80 or like 200 or 500? Like, and the interesting part that the implant will keep going because you already
It's
technically-
self-tapping, right?
Yeah,
it's
self-tapping.
Most
yeah.
implants are self-tapping.
Exactly. So taking the risk of over torquing and maybe probably the chance of having a crystal bone loss 20%, that could be like really
Disastrous.
disturbing.
Yeah.
So I would be like, let's just untorque, take it out, over drill, put it back at
What if
40.
you can't untorque? So let's say, for example, a Straumann. That used to happen to me when I used to use Straumann. Place it has a locksum, it breaks.
Breaks. Yeah.
So then now I need to untorque it, and the locksum breaks. The locksum breaks, and the locksum breaks.
Well, look,
Or do you just get the extractor and then just
yeah.
you're
I
expanding?
do everything possible just not
Okay,
to over
okay.
torque it, honestly, because I've got some cases with bone loss, and I think that the reason that happened is the over torquing.
Really?
Yeah.
Even though it was deep? Then not crestal level. It was deep and it still
even
had
though like
bone
you
loss.
see this like saucer shape.
Yeah.
And the only explanation that I could get is the over torquing.
No, not because it's Biohorizon?
Is this
Are you gonna censor that or?
It wasn't Verizon that day. It wasn't, but yeah.
It's interesting just to add to that I was just reading like a paper I think a few months ago that said the complications that they saw from over torquing is the implant break.
Yeah, that's what I worry about the most.
That's
Or
the
the
worrying
piece,
bit,
the
yeah.
piece that you're using to torque breaks
good.
inside.
Yeah. Well, I've seen this. It never happened to me that the piece that what they call it the driver breaks inside the implant. It happened to one of my friends. But if this happened, this is also a disaster. You have to remove the implant. So going.
It's not worth the risk, is what you're trying to say.
Yeah, exactly.
Yeah.
I mean, it's gonna take like 5 minutes of your time.
Yeah.
Just remove it, over drill, and put it back in safer.
Yeah.
It's not worth it.
I think it's not something that you would routinely do.
Yeah.
It doesn't happen to you all the time. That's the
It's
thing.
not a common thing. So
Yeah.
you're drilling and you're thinking
Yeah.
this is really dense bone.
Yeah.
You know what I mean?
Yeah.
Like you're
Yeah.
doing 2 implant over
Yeah.
dentures.
And sometimes
And
you
then you
over
think-
drill, but it's still, you're placing the implant, and I'm like,
And
oh
I'm
my
like,
God,
oh
already
God,
torqued out.
Exactly.
Yeah.
Exactly. And then you put it in and it tells you, if you look at the digital pathway, the protocol, it tells you, okay, use extra drill if it's dense. Even the Astra implants have
Yeah.
that. And then you'd go in and because you always want to get that sweet spot of getting primary stability, but then not over talking it. But then if you do, I mean, from the experience I've had in Florida, you would back it out, okay, slightly, and then go back in again. Back it out, and then go back in again, and you realize that it's within the 50.
Yeah.
Does that make sense?
Yeah.
Without drilling. So I wouldn't go back and drill again. The drilling bit is like when it's completely just.
But
the
thing
wrong size.
is like going back to the torque wrench. The old torque wrenches are 60, 50, but the new ones, if you look at the BLX, I think BLX is 120. It's showing like the maximum on the torque wrench is 120. Same thing with Southern implants. Same thing. Like, so it's becoming normal to get that high insertion torque at the correct depth. This is why I mentioned is it the deep enough? Because if it's a crestal, then yes, that could happen. Because you're putting so much stress on that crest. But if it's deeper than the crest, then it could be. Again, it's a very debatable topic, of course, because our entire education told us, hey, it has to be 35 to 40, not more than that, or else you get in some necrosis. But I would say most of my implants are like probably over 50, I would say. Over 50. Anything less than 20, I would submerge. I would just like let it underneath the gums.
And surprisingly, that still works. If you look at the classic literature that tells you, you know, if you don't have primary stability, then it's not a successful implant. But that's still, you come back and it's integrated.
But what is primary stability? Because I've also, because one of the main things, for example, in immediate implants is getting primary stability.
Right.
But I've had immediate implants with like 15, and I submerged it and it was fine. You know? But so how much primary stability is good enough? You know?
I think to me that's more of a key factor if you're loading. If you're not, then just bury it and just come back and let the biology take its course. But if you're trying to load, I think that's when you think, okay, this is the case.
It was interesting. I think we attended a conference together, the oral rehabilitation one, and there was this lecturer that said something very, very interesting. He measured how many threads are needed for primary stability. So, and the conclusion was exactly what, you know, when like as a carpenter or a builder, there's like a screw and nut.
Yes.
The nut has five screws, and that is enough, physically enough to hold. And then so he used that concept into implants, and then he retrospectively looked at a lot of the implants they did, immediate implants, and saw how many threads from the planning, and he found that 5 threads. But sometimes, obviously, you have a little bit less on one side, but then you compensate with another side. You know what I mean? Like, let's say an immediate implant, obviously, it's going to be more exposed here, but more threads here. So as long as you got 5 threads, he said it guarantees you primary stability, which I thought was very, very interesting. If that was actually the truth. So I always kind of keep an eye on that when I'm doing my planning. Okay, I kind of want 5 threads. But again, what is enough primary stability? You know, I don't know. I really don't know.
Yeah, I mean, like how many times like you place an implant and you're placing the cover screw and it moves.
Yeah.
And you just let it in.
Yeah. I kind of push it in a little bit more, like with the cover screw. I like holding like, oh shit.
Hoping to get more primary stability, but it works at the end. I mean, look, literature say a lot of things, and I remember one of the examiners, if you know him, Dr. I think Dave Filton.
Yes, of course.
So he was one of the examiners that I got in my full rehab case. So. During the exam, you keep mentioning and saying like rationales for every single step and everything. You have to have a good rationale, good study, good article to back it up. So I was like giving him like those studies that I went through. So he was like, you know what? Don't believe everything you read in articles. So a lot of things are mistaken, and a lot of things were made up, and so don't believe everything you read.
Exactly.
So that was interesting when he told me this. Like I don't forget this. I never forgot this because a lot of things that you read in literature that don't make sense. Don't make sense.
Yeah, and I think that was the biggest skill I got in residency is being a critical thinker and critical observer for the literature. Like be like, okay, this methodology doesn't make sense. You know, like it really doesn't make sense, and you have to be critical of literature because, unfortunately, let's be honest, most of the research is done by pharmaceutical companies. that have like a kind of like a bias towards a certain implant, a certain toothpaste, toothbrush, whatever it is. You know? So you have to be critical.
Everything gets published.
And everything is
Everything is
you could publish anything.
Yeah.
You could create some research that's done from your back shed, and it will get published somewhere, whether it's in China or in Western Europe. That's not an issue, and that's why you need to be very critical with the methodologies you said and how robust the research was.
Right. Yeah.
That's important.
Okay, so let's get it all together and conclude. What's your favorite procedure? You know, as prosthodontists, we really have like a very wide scope. We're lucky that we have a very wide scope because then you get to like perfect a single one or really enjoy a single one, but still enjoy the rest. What is your favorite?
Well, interesting question though. My favorite one is the surgical part of implant. Not the restoration itself, but the surgical.
The actual implant. But which procedure exactly? Is it an immediate? Is it an implant with bone graft? Is it a sinus?
The immediate, of course. The immediate extracting, placing graft
Anterior,
area,
posterior, or
the posterior.
Posterior?
Yeah, that's when I really brings joy to my heart.
It's like when you extract that tooth and you see that septum.
Yeah, that island in the middle. Oh my God. Boy, that makes my day.
What about you?
Mine is I suppose implant prosthodontics generally, but in specific, I think when it comes to oncology and trauma cases, I really like I think nothing gives me more. I mean, my experience has been somewhat limited, but it's been very rewarding to see those patients who have gone through a lot. You know what I mean? Where they start off with, I wouldn't say a 0, but minus. And their expectations, they just want something simple and something that's functional. And I think to me, that's been very rewarding, trying to treat those cohort of patients. And it's appreciated by them.
Yeah.
I think it goes both ways. But the most rewarding thing, I think, is that it's not, you have to think outside the box. I think that's what I liked about those cases. You think, okay, this is not going to be a conventional case.
Yeah.
I have to think and see, is that going to work? Will I have to think about a plan B just in case it doesn't work?
Well, as prosthodontists, we always have plan B and C, right? And that one is even more when it comes to maxillofacial prosthetics.
Absolutely. So I think that to me has not, in my career so far, nothing has given me more joy than treating them.
Amazing. Yeah, for me, I would immediates are like my favorite. Like when I'm planning a case, because every single case I actually plan it on like the software, and then I take a look at the X-ray, and then I compare it with my plan. And obviously we do it almost always freehand, right? Just to save cost. And I'm just like, wow, that was exactly like in the septum, then into the mesial roots. It makes my day.
Yeah, especially when you look at the X-ray afterwards, like after healing, and you see all of this bone around the implant, and it's
so satisfying. Okay, so we'll conclude by, can you tell everybody where can people find you? If they want to collaborate with you, they want you as their doctor, where can people find you?
Well, I work in 2 practices.
Okay.
In Abu Dhabi, Hollywood Smile Medical Center, and outside Abu Dhabi in the city of Shakhbout, California Medical Center.
Amazing.
Yeah, they can always interact with me.
Okay.
Have my
we'll put in
page.
the your contact information, your email, not your cell phone.
Thank you.
What about you?
Social media, if they wanted to ever interact. Advice, I suppose, or just
because I think this is also very important for future dentists or future specialists. Let's say
that's it.
It's always nice to get perspectives from different experiences and everything, and usually people try to reach out. So I'd like to thank you guys for coming in. This has been a lot of fun.
It was,
and I'm looking forward to our next journal club, which is our first ever journal club. So I thank you guys for being the founding fathers of hopefully a lot more. Thank you guys for coming. And
Thank you for having us.
And I hope for many more.
Thank you for our efforts.
Thank you.
Thank you.